Okay, so we can get started. So today we chose to talk about sickle cell disease, particularly about one of the most devastating complications, which is stroke, as well as just cerebrovascular disease associated with sickle cell anemia. Please do stop me at any point if you have any questions, or raise your arms and then raise your hand, and we can talk about at the end. So stroke and sickle cell disease is considered to be one of the sickle cell disease is considered to be one of the commonest causes of pediatric stroke. I'll focus mostly about pediatric sickle cell disease today. Of course, stroke is considered to be one of the most devastating complications that is associated with a lot of disease, morbidity, and mortality, unfortunately. So, sorry, Saskia, I'm not keeping an eye on the chat or the hands. Are you able to keep an eye on that, please?
Bear with me a second.
If there's anything that if I need to stop or anything, let me know.
Yeah. If there's anything in chat that requires you to stop, I'll let you know.
Amazing, thank you, thank you. Okay, so children with sickle cell disease are considered to have a 300-fold risk of developing stroke compared to normal counterparts. And as we know, the most severe phenotypes for sickle cell disease are those with sickle cell anemia. Those are the homozygous sickle cell genotype, as well as those with S beta 0 thalassemia. Now we can have people with overt stroke with a significant motor deficit or other deficit, and we have patients that have silent cerebral infarcts. So when we think about the pathophysiology of sickle cell disease or cerebrovascular disease, we think about the macrocirculation and the microcirculation. Often patients with overt strokes have evidence of sickle vasculopathy in the large arteries, particularly the internal carotid artery, mostly the intracranial part of the internal carotid artery, and also the proximal middle cerebral artery. And we think those two large vessels supply the blood supply for the majority or the biggest territories in the brain. Those with silent cerebral strokes typically have disease affecting the territory of the penetrating arteries or smaller vessels, so the microcirculation. But again, it could be interchangeable, and people can have disease anywhere and present in different ways. Now, we know that there is an abnormal interaction between the sickle red blood cells and the cerebral arterial endothelium, which is the majority of the sickle cell vasculopathy occurs at an endothelial level. And we know, again, because of sickled cells and them hemolyzing, we have an increased adherence of sickle cells to the vascular endothelium, but that unfortunately results in an activation of the endothelial cells, and subsequently that gives us a hypercoagulable state and also an alteration of the vasomotor tone of the cerebral vessels. And the alteration of the vasomotor tone subsequently causes stenosis in some patients, complete occlusion in others, partial occlusion in some, and unfortunately also moya-moya syndrome with collateral formation. Now we know that this has significant morbidity and mortality for patients, but unfortunately, despite our best efforts and aggressive hematological management, some children with cerebrovasculopathy might still have progression of their vasculopathy and also recurrent strokes. Now, if we think about the endothelial biology in sickle cell anemia, we know that the endothelium in the normal state is at a quiescent state or just a deactivated normal state. It's not really deactivated. It has a lot of physiological functions, but it's a normal state where it's not causing any problems. In sickle cell anemia, the endothelium, because of various reasons, can become activated, and also we can call it dysfunctional. When it becomes dysfunctional, it can cause a lot of shift in the physiology of how it functions and cause some harmful effects. Now, some of the reasons for endothelial activation and endothelial dysfunction could be simply the polymerization induced red cell sickling, and we know the pathophysiology of that, or just that the body in sickle cell disease has a systemic inflammatory state, and that results in an abnormal expression of certain adhesion molecules, whether it's on the surface of red cells or white cells, and even in some cases, platelets. And in addition to platelet activation and platelet adhesion, we have activation of the coagulation system that might further compound the cerebral vasculopathy and compound the degree of cerebral occlusion, cerebral vessel occlusion. We all know very well that there's a biodeficiency of nitric oxide in sickle cell anemia patients, as well as nitric oxide resistance. And there are many, many reasons for that. That's, I think, at least 7 to 10 reasons of why nitric oxide might be deficient in sickle cell anemias. And as secondary to nitric oxide depletion, there could be a paradoxical vasoocclusion or worsening vasoocclusion. And as we know, sickle cell anemia patients, because of the sickling and the abnormal cell adhesion, there is a stasis situation at the anivascular bed. So when stasis occurs in the cerebrovascular bed, we could have further worsening of reduced cerebral blood flow. And one of the major things we always think about is reperfusion injury, because in sickle cell patients, if we think about actual vaso-occlusion because of sickle cells, we know that those sickle cells are not all permanently sickled. Some of them are sickled temporarily, and when they are reoxygenated, the sickling is relieved. So there is always a mild degree of perfusion and reperfusion injury at the level of the brain tissue. So we think that if there's reperfusion injury, it's physiology that results in an overall inflammation. Inflammation with all of its wonderful side effects of macrophage activation, other cytokine activation, generation of oxidants and free radicals, of course, as we discussed, endothelial activation, and nitric oxide depletion, of course, and all of that is interlaced with red cell sickling. And of course, everything is compounded by red cell hemolysis. We come to the conclusion that the majority of the injury at the vascular bed is inflammatory in nature. Okay, but at the end of the day, we have inflammation, we have reperfusion injury, we have red cell sickling and nitric oxide depletion. All these things together have an end result of tissue injury. Now, a specific type of vasculopathy that happens in sickle cell anemia patients, and we see it even in a UK setting, is moyamoya. So when we say moyamoya syndrome, we're referring to moyamoya that is associated with something else, whether it's sickle cell anemia or neurofibromatosis in some patients, for example. And the sickle cell related moyamoya, we know that moyamoya is a progressive stenosis that occurs in the large vessels, so particularly the distal ICAs and its branches, the MCA, and in some cases the ACA. But the hallmark of moyamoya is the development of collateral vessels. So that kind of little tuft of new vessel formation, that neurovascularization, that is the characteristic puff of smoke or hazy appearance that happens when we look at it, when we look at a scan, whether it's MRA or CTA, we have characteristic collateral formation that is moyamoya disease. Now, the basal collateral vessels in moyamoya are derived, as I said, from the major vessels, which are the ICA, internal carotid, the MCA, middle cerebral, and the ACA, the anterior cerebral branches. And if untreated, the progression can continue for moyamoya disease. The progression of ICA stenosis and occlusion continues until the collaterals themselves no longer receive blood flow, and we are left with a cerebral circulation that's completely dependent on the external carotid artery collateral vessels, and that can result in devastating results, whether it's cerebral infarction or even sometimes hemorrhage at the level of the neurovascularization. Okay, so in terms of sickle cell related risk factors, so sickle cell stroke risk factors, we know that in pediatrics we monitor the transcranial Dopplers and we look at the velocities of blood flow within various vessels. So if we have high blood velocity on a transcranial Doppler, we are concerned about the risk of stroke. We have severe anemia, especially an acute drop in hemoglobin that could be a risk factor for stroke in children. And there are some reports, of course, of a relationship between high white cell count, hypertension, and even patients with silent cerebral infarct, they could be at a more higher risk of developing stroke. We know that patients with nocturnal hypoxemia, particularly with obstructive sleep apnea, could have a higher risk of stroke. But those patients, we normally try to monitor them closely and pick up the conditional TCDs and abnormal TCDs as they progress. And we have certain things that we can do for that. And some people say that there's a familial predisposition. If there's a family member who has had a stroke was related to sickle cell disease, it might be more likely in siblings or other family members. Okay, so we know that 11% of patients with sickle cell anemia would have had a stroke by the age of 20 years. And of course, we're talking about the untreated state or unmonitored state. And we know that 75% of those patients have ischemic strokes and about 25% have hemorrhagic strokes. And when it comes to silent cerebral infarcts, those are cerebral infarcts that are not associated with any clinical manifestations, although the majority of them would have cognitive difficulties. But for silent cerebral infarcts, we know that they are found in around 37% of children. As usual, cerebral strokes or infarcts, silent cerebral infarcts are more common in patients with SS or S beta 0 compared to other genotypes. And again, in the untreated population, we know that strokes would recur in 2 out of 3 patients, mostly within the first 2 to 3 years after the initial brain insult. Okay, so this is just an MRI showing evidence of cerebrovasculopathy and also with a lot of collateral formation, Moi disease. Okay, so for transcranial Dopplers, so of course this depends on availability of this modality of monitoring, but it's a very effective way in identifying and assessing risk of stroke. In the UK and as per guidelines, we start from the age of 2 and we stop at the age of 16. And it's an ultrasound Doppler study that looks at the Doppler flow velocities measured in the distal ICA and the MCA, the ACA, and the PCA. Ideally, we should be using TAM-V, which is the time averaged mean of the maximum velocity. That is what all the clinical trials and the studies have used to assess risk. But again, this largely depends on what the practitioner can do and if it is available or not. We also know that about 10% of children with SS or SBT0 will have had an abnormal TCD at some point in their life. Okay, so the benefit of the TCDs is that it helps us identify and pick out which patients would be at higher risk of stroke and treat them accordingly. But there are some challenges. Of course, it is an ultrasound Doppler technique. It is entirely operator dependent, and there could be some variability in the reporting depending on what technology is available where. So what we're trying to identify is cerebral blood flow. We want to know if there's any focal reduction in cerebral blood flow, or if there's any increased global cerebral blood flow that would eventually decrease the cerebral vascular reserve. Because if we know that the whole brain is having an increased blood flow, when there is a time of, say, increased metabolic demand, when there is an inflammatory or increased, just a heightened systemic unwellness for a patient, they will not be able to compensate and increase their cerebrovascular reserve. So we're looking to identify certain velocities, and of course, as you all probably already know, we have certain parameters. So we look at the velocities. If they are more than 200 centimeter per second, particularly in the MCA or in the distal ICA, that is considered to be abnormal. And this is associated with a 40% risk of strokes within 3 years. Now, we always say that if it's less than 170 centimeters per second, we consider that to be normal. If it is anywhere between 170 and 200, we call that conditional. So it's neither here nor there, and there are certain considerations for the people that have conditional TCD velocities. And we also say if the velocities are more than 240 centimeters per second, these patients are more likely to have accompanying abnormal MRI findings. Because it's not always that if we have an TCD velocity of more than 200 that we're going to find something in the MRI, but if it had gone up so high that is above 240, we're likely to find abnormalities in the brain tissue on MRI imaging. Now, when we say velocities less than 170 is normal, we also are sometimes worried by too low velocities. So if the velocities are seen to be lower than 70 centimeter per second, this could potentially suggest occlusive disease because we know that blood flow could be dramatically reduced downstream from where there is a cerebral stenosis. So if a person has persistently low velocities, less than 70 centimeter per second, we often say that it would be beneficial to have some sort of angiography, whether it's MR angiography or CT angiography, to look at the vessel anatomy, because the TCD will not tell us very much about the anatomy, it will just tell us about the blood flow. Okay, so because stroke has been very early on identified as one of the most devastating complications, there have been quite a few clinical trials trying to identify the best management approach. And we have really robust clinical trials that we base our clinical management on nowadays. So we know of this top trial. So this was in 1998. This was a randomized trial of allocating patients to a chronic transfusion program versus standard of care in those with abnormal TCD velocities. And this well-designed study has shown very clearly a huge benefit of starting a chronic transfusion program in patients with abnormal TCDs with a reduced risk of stroke by 92%. That's one undisputable benefit of transfusion program, and that has changed our clinical practice. Then came along this STOP2 trial. This was much later in 2005. And the STOP2 trial looked at children already receiving a chronic transfusion program because they had an abnormal TCD. And the question was whether they are randomized to continue transfusion or stop after a certain amount of time and see what's going to happen. And this study very clearly showed that discontinuation of the chronic transfusion program was very abruptly followed by a high reversion to abnormal TCD velocities and also higher risk of stroke. So because of the STOP2 trial, there has been recommendation to continue long-term transfusion program. However, there was also the TWITCH trial that looked into those patients and to see if there is any benefit from substituting transfusion with hydroxycarbamide in children that have been on a transfusion program because of an abnormal TCD, but had no severe vasculopathy. So this was a phase 3 randomized open-label non-inferiority trial that compared the two modalities of treatment. And it concluded that as long as there is no cerebral vasculopathy, and they do say severe cerebral vasculopathy, or a prior history of a TIA, hydroxycarbamide may be offered to such children after at least 1 year of blood transfusion. However, they leave the duration of transfusion quite open, and they say it should be tailored to the individual patient, but it should be at least 12 months. And the other thing, caveat about it, is that when we say we switch patients from transfusion to hydroxycarbamide, we must ensure that we reach a maximum tolerated dose with the hydroxycarbamide before we stop the transfusions. So that's one of the things we have to be careful about when we switch them from a transfusion program to hydroxycarbamide to ensure they have a better chance of remaining on hydroxy and not reverting back to transfusions because of abnormal TCDs. Okay, so let's suppose, of course, a patient comes in already on with a stroke. So what are we going to do? So we have to have a very high index of suspicion for any sickle cell disease patient that presents with focal neurological abnormality. And sometimes the focal abnormality is an obvious weakness of a limb or abnormal gait of some sort. But sometimes it's much more subtle than that. It's sometimes just behavioral changes or speech abnormalities or just numbness or tingling. So we have to have a very high index of suspicion, especially if there are clinicians who are not used to looking after sickle cell disease patients, seeing those patients. So we always have a lower threshold to assess those patients and scan them. And in pediatric settings, the majority of the patients that do develop strokes don't have them de novo, so they wouldn't come from home just with a stroke, although I understand this can be a bit different in the Zambian setting. But for us here, the majority of them would have it in coexistence with.
I'm all right, thank you. Radiology. I'm okay, thank you. Does radiology ever open?
With acute chest syndrome. So patients would be acutely unwell. Most of them would be in an intensive care setting, and in the context of having an acute chest syndrome, may sometimes develop a cerebral infarct or overt stroke. Now, the ideal gold standard imaging technique for stroke would be an MRI or an MRA. MRI and MRA, actually, that's recommended to confirm diagnosis. Of course, we include diffusion weight imaging for recent infarcts. I think the radiologist would automatically do that if we say this patient has sickle cell anemia and we're suspecting an acute stroke. In the emergency setting, if an MRI is not available, and this is not uncommon even here in the UK, we always recommend the next best would be a CT brain with the CT angiography is possible. However, sometimes even that is not available and not possible. And if cerebral imaging is not possible in an acute stroke with clinical suspicion, there's no need to delay treatment. So you can just go ahead and emergency treat these patients without any imaging. In the first setting, of course, supportive measures are important. We maintain hemodynamic stability because we know that having a stable blood pressure is important for saving cerebral perfusion. And also monitoring simple things we can overlook sometimes, like glucose, oxygen levels, and that's recommended for any case. And that's just standard for any pediatric stroke. Now, the gold standard treatment for sickle cell disease related stroke is emergency exchange transfusion, and that is strongly recommended. Having said that, if it is available, that is the ideal gold standard. If it is not available, we have to think of other modalities. But
I have to tell you, I'll just go to translate, then I'll go to pharmacy.
Saskia, do you have any power to mute people that are unmuted?
I can't mute other attendees, I'm afraid.
Okay, that's okay. Thank you. So when we do an exchange transfusion in sickle cell stroke, we are aiming for a sickle percentage that's less than 30%. And we're aiming for an increase of hemoglobin because we know that the majority of these patients would be coming already with a lower hemoglobin, but that's not absolute. So we try not to exceed a hemoglobin of 120 gram per liter or not to exceed a hematocrit of more than 0.34 because we don't want these patients to have such a high hemoglobin and hematocrit with an increased viscosity that would further compromise cerebral perfusion. So we always recommend an emergency exchange transfusion if possible. If not possible, or would be a significant delay in exchange transfusion, and there is some room to give a top-up blood transfusion, a simple transfusion is recommended to increase the hemoglobin level to about 100 gram per liter. Now, this may or may not achieve a sickle percentage of less than 30%. So if it had achieved it, then that is acceptable. If we have not achieved a sickle percent of less than 30%, then we might sometimes need to follow that up with a partial exchange transfusion to achieve our goal of 30%. So this is the gold standard of acute management, the hematological management. Other patients, or especially older patients, there might be some role of thrombolysis, but it's not recommended in pediatric patients because we don't think the pathophysiology is embolic or thrombotic in nature. And similarly, we don't have any place for antiplatelets in pediatric stroke. In fact, I think the use of antiplatelets is always try to avoid that in pediatric patients, but more so in sickle patients, especially those with moyamoya, because we think that might contribute to increasing their bleeding risk from the collaterals. Okay, so once the acute phase is treated, the acute stroke is treated, these patients should automatically, because of clinical trial knowledge, should automatically be started on a regular blood transfusion program for secondary stroke prevention. And the initial aim is to maintain a sickle percentage of below 30%. And we're trying to maintain a pre-transfusion sickle percent of less than 30. So that's a long-term sickle percentage of less than 30. So it's not enough that they achieve a 30% after their transfusion. It is important that they maintain that until prior to their next scheduled transfusion. We know that if a stroke is left untreated, as we mentioned earlier, about 90% of them will have a recurrence. And then the transfusion therapy, keeping an S of less than 30, reduces this risk to less than 10%. So that's a really, really significant improvement in the risk of stroke. Now we monitor their progression, we monitor how they're doing on blood transfusion program, we check the S%, we continue doing regular TCDs, and often we have to repeat their MRIs every 12 to 18 months. But of course, as we all know, there are some side effects of blood transfusion, especially regular transfusion programs. And one of the major side effects is iron overload, and we have to be very mindful about that. And when before starting patients on a transfusion program, when we're consenting them to this, we always mention the risk of iron overload and the subsequent almost inevitable need to give them iron chelation at least a year after they have started or when their ferritin levels have creeped up above 1,000. So other side effects or adverse effects that we talk about when consenting for a transfusion program are acute hemolytic transfusion reactions that are very, very rare in our setting, and also acute non-hemolytic transfusion reactions. That could be the simple transfusion reaction that we get with allergies, anaphylaxis, and otherwise, and also delayed hemolytic transfusion reactions and red cell alloimmunization. Now, DHTR, delayed hemolytic transfusion reactions, and alloimmunization are one of the major side effects or complications for red cell transfusion patients because they definitely complicate their transfusion history and make further transfusions quite challenging or risky. Although they are considered to be rare, but we do see those often, unfortunately. And if it is just an alloimmunization with an antibody that we could match for and manage, that should be okay. But in some cases, we have patients with hyperhemolysis and an unidentified antibody that makes continuing a transfusion program very challenging and sometimes impossible. So, of course, we talked about iron overload and infection transmission, which is quite rare in our setting, but still there is a small, tiny risk of infection transmission because of a transfusion program. And we often mention to the patients when consenting them that there's a very, very small risk of that, although very rare in the UK. Okay, so now there's quite a lot of dispute about when you need to scan a child. Of course, the first thing we have to think about is availability of these imaging modalities anyway. So I think in our setting, thankfully, because we have this available, we often think when do you need to do an MRI really on a child with pediatric sickle cell disease? There are not many situations where you want to, but if it is available, then we could consider the following. Of course, sudden onset of neurologic abnormality, we're thinking about an acute stroke, that's very clear. If a child has severe or recurrent headache that is not severe enough to come to an emergency department, but they do complain of it over a period of months, then we could scan these children. Some people have a lot of thoughts about routinely scanning children every 6 years. I don't do that in our service, but I am looking into how the Americans do it. I think they do scan at the age of 7 and then every 6 years subsequently. We can have a discussion at the end of how what people do. Of course, if a person has a TCD velocity of more than 170, that is tipped over into the conditional range, or they have very low velocities, less than 70, and we're thinking about occlusive disease, that's a good idea to scan them at that point. If we have a TCD that is incomplete, because despite all our efforts, there are some children that just have inconclusive TCDs, or they don't have a good window for Doppler imaging, or the operator just cannot get a reading. So in those cases, we would have a lower threshold to scan them to identify any vasculopathy that is causing that. And if we have a child with TCD velocities that are asymmetrical, very excellent velocities on one side and profoundly different velocities on the other side, and especially if it's consistent throughout all major 4 vessels, we would scan those children. Turbulent flow is another one. Patient with cognitive delay is another one, because in cognitive issues, we think about patients that have silent cerebral infarcts that we'll never see on a TCD. And of course, if a stem cell transplant is being considered, it's always important to have neuroimaging to assess their baseline cerebral state. Okay, so for children with silent cerebral infarcts, we know that 1/3 of patients with sickle cell anemia would have silent cerebral infarcts, and that is also despite optimal management. The cerebral infarcts may vary in extent. Some of them could be even having widespread extensive cerebral infarcts that may remain clinically silent. As mentioned earlier, we identify those on MRI, MRA, and they often present with cognitive impairment and non-neurological deficit. In those patients, we would discuss hydroxycarbamide, would offer it, and also transfusion therapy. In the patients with silent cerebral infarcts, regular transfusion may be appropriate, and we discuss them if there is significant impaired cognitive function or progressive deterioration of cognitive function, rather, and also if there are progression of silent cerebral infarcts on serial MRIs. So as I mentioned earlier, we'd often be rescanning these patients every 12 to 18 months, and if we see that there is clear progression of silent cerebral infarcts, that might be a reason for us to push the parents towards a transfusion program. Evidence of intracranial or extracranial vasculopathy on MRA, that might be another reason for us to say, well, you might be better off on a transfusion program than you are on hydroxycarbamide. And of course, it's always a discussion with the family. And if there are any other comorbidities, example, if we already know that there are conditional TCDs or renal impairment or anything that would preclude us from giving hydroxycarbamide, then we might also opt for a transfusion program. Now, in all cases, it's always a discussion, and it's always what the patients and parents would accept. Okay, so subsequent actions or other things, other considerations for patients that have had a stroke. We often talk about overnight oximetry or inpatient cardiorespiratory studies to assess overnight oxygenation, because we know sleep disordered breathing patients might be at a higher risk. Now, this is not essentially just a subsequent actions. Often it is the opposite. We often do these things prior. If we have a child in the clinic that is complaining of snoring or choking overnight, or we have a suspicion of obstructive sleep apnea, we'd be doing an oximetry study and also a cardiorespiratory polyography prior to them having a stroke, and that's the hope usually, but sometimes we have to do retrospectively to identify cause of stroke. Now, for patients that have sleep disordered breathing or evidence of obstructive sleep apnea, they might benefit from an ENT review, especially for consideration of removing their adenoids or their tonsils. So we send them for an adenotonsillectomy. And also respiratory referral might be beneficial for some patients to assess their lung function. In terms of cardiological assessment, we can do an echocardiogram and we assess for paradoxical embolus if they have a patent foramen ovale. However, for the majority of children I mentioned, we don't think the pathophysiology is embolic in nature, but it's worth doing that for excluding other causes, especially in older children or maybe teenager age. Thrombophilia screen, again, is not something that is recommended for sickle cell stroke, but it could be considered, especially if we have a very obvious family history, or if there is any association with an obvious venous thromboembolism or even arterial thromboembolism. Something to consider, and we can talk about in the end as well, is HLA typing of patients and their siblings who are not affected by sickle cell disease, because one of the challenges we have is, as I mentioned earlier, despite optimal hematological management, some patients still progress. And at that point, we're left with not very many options, and stem cell transplant is an excellent consideration for these patients, whether it's for secondary prevention or even, in some patients, primary prevention of stroke. Assessment by pediatric neurologists where available is also recommended for certain considerations, and other things like physiotherapy, speech and language therapy, occupational therapy. Input is often needed if available. That would be the ideal situation. And if somebody is left with a significant motor deficit, neurorehabilitation is also necessary. Ophthalmology assessment for those that have had a stroke that is associated with their visual pathway is useful, looking into their visual field and their visual acuity. Also neurocognitive assessment by clinical psychologists. And for neurocognitive assessment, we tend to repeat those at least 2 or 3 times in a pediatric service, depending on when their stroke started, because we know that having had a stroke, a cerebral insult, can result in neurocognitive impairment that could be progressive. So we try to keep an eye on that where available. Of course, other things, this is very dependent on where the patient is, but if you do have community pediatric services, that might be necessary and for a bit of support in school. And then we continue, as I mentioned earlier, to do the regular TCDs. But sometimes after a child has suffered a cerebral stroke, their TCDs can become uninformative because of the amount of damage to the cerebral vessels. So in some patients, we try to do them, and if we don't have any useful information from them, we often stop and just revert to monitoring them with an MRI, MRA every year and a half or every 2 years. And as I mentioned, regular MRI, MRAs depending on the patient's severity, including the carotid vessels and the vertebral arteries or extracranial vessels, again, to assess for progression. That's what we normally would do. So this is how we would manage acute stroke, how we would manage chronically patients that have had a stroke or those with a silent cerebral infarct, and how we manage patients with abnormal TCDs. And I wondered if anybody had any questions or any comments on how you manage your patients, how differently these recommendations would be in your setting, and also wanted to have some input from Subarna if she had any additions to what I've mentioned. Thank you very much. Okay, great. Subarna, any comments?
No, so thank you for a very comprehensive sort of walk through the whole thing. I guess it'd be useful to know how, having had, so how you manage the sort of not quite abnormal but conditional Doppler tests. If you don't have access to Doppler, how would starting hydroxycarbamide early might help, and also the role of, I mean, it's worth discussing about, how you manage acutely with, I mean, obviously there is with sickle strokes, you're not using any aspirin or any antiplatelet agents, so that's something that is worth mentioning anyway. Just a few comments on, I guess, if the routine sort of assessment and management of strokes are difficult, how would you mitigate for the risk? I'm interested to see what everyone has to say.
Yeah, thank you very much. Maybe I can just answer the first one about what we do with conditional velocities. So for the people that have a velocity between 170 and 200, we'd always recommend hydroxycarbamide as a first line. But again, we look at the conditional velocities and we split them sort of into 2 groups. So the low conditional would be roughly between 170 to 185. Or 180, and then the high conditional would say 180 to 185 up to 199 or just under the 200 mark. So for the ones with the low conditional, we'd be pushing towards hydroxycarbamide and trying to start that and achieve a maximum tolerated dose. And for the high conditional patients, we can still do hydroxycarbamide, that is fine, but we would take into consideration the presence or absence of vasculopathy. And if there is vasculopathy and they have very high velocities that are just under the abnormal stage, we would be recommending or pushing parents more towards a transfusion program. And we do definitely take into consideration their MRI, MRA appearances. But maybe we can take some comments from the Zambian team about what their experience is and how they manage patients, and depending on availability of various things.
Thank you so much, Tama. That was very comprehensive, and I think as a team, uh, definitely some reminders there, but also just some things to think about in terms of research and ways we can also improve care. I think I'll speak a bit on the acute care, and maybe Dr. Chira Ozima can also come in at some point. So I think in terms of acute and emergency care, we do have we do have some challenges, especially when it comes to imaging. Um, Even more so now with some of the facilities for imaging not being available or functional. So that one has definitely been a challenge. So we lean more towards the clinical diagnosis and clinical management thereof. So we do not usually wait for any imaging. CT, just CT scan with contrast, even is usually what would be early available, but not in the emergency situation, like within 12 or 24 hours. But MRI, MRA is even a bit more difficult because of some of the logistical challenges around ensuring that we have the children sedated enough and basically logistical human resource. But having said that, in terms of acute management, we do manage our patients in intensive care units, and the protocols are put in place with respect to blood transfusions and also monitoring the hemodynamic stability, and also involving the pediatric neurologists as well in the management. Maybe Uzima, you can come in as well, or Dr. Chunda, I don't know if you wanted to add.
Yes, so it's just to retaliate what you have shared in terms of management. I think our biggest challenge really is follow-up of these patients, who quite often, even when we've put a management plan in place in terms of them coming for prophylactic blood transfusions or being on hydroxyurea, quite often our patients default, and mainly because, again, quite a number of them are not able to sustain the frequent hospital visits that they need to pay for the prophylactic blood transfusions. And then also quite a number of them are not able to carry the burden of having to source funds for them to procure the hydroxyurea. Okay, so those are actually the challenges that we tend to have. I was actually going to ask, but you had answered this question. I was going to ask the benefits of doing a TCD after a stroke, because the main group of patients really we're doing TCDs on are patients who've not had stroke, patients that, of course, we are right now we are limited in terms of how many staff we have who actually have the expertise to do TCDs. Okay, so we do have one nurse who has been trained working alongside another nurse that have been doing screening for the last, I think, 2-3 years. And we've got quite a good database of TCDs that have been done on our patients. And these patients are actually being followed up within our outpatient clinics. But again, sustaining that follow-up and preventing, secondary stroke is really one thing that we're struggling with. I think those are my comments for now. Thank you.
Thank you so much. I think it's we have to acknowledge these challenges, and it could be quite difficult. I wonder if Subarna, you want to mention anything about just starting on a blanket dose of hydroxycarbamide, if other modalities are challenging or follow-up is a difficult thing.
Yes, I mean, both sort of low fixed dose and the escalating dose hydroxycarbamide has been used. Hydroxyurea has been shown to be very effective in their own ways safe and effective in the African setting. With excellent work done in many African countries based on that. And we have learned very much from the most recent studies that have been conducted in many countries in Africa. And what at the moment, from those learnings, we are really much more confident in starting hydroxyurea in our patients and increasing to maximum tolerated dose over here as well. In terms of universal, I think the challenge mainly, obviously, in the African setting is as Catherine quite eloquently said, we can't, there is that sort of the element of being out of pocket. And I know we've discussed this before when we were in Zambia, that although there are some formulations which I think are available, but they're only available free of charge in the local clinics, in the teaching hospital clinic. But that means that the family will have, because it's compounded and dispensed from within the hospital. To be honest, we had the same issue only about 5 or 6 years ago. The hydroxycarbamide used to have to be compounded and dispensed locally, and patients had to come and collect it every month. And that is very challenging for patients wherever you are, and so the main challenge, I guess, to see is how the universal availability of hydroxycarbamide, forget acceptability, which is a big issue on this side of the our end of the world, but I mean that is something which would be obviously a challenge that requires addressing, I guess, in the future.
Fantastic. Thank you very much. Has anyone got any comments or any questions at all? Perfect. If you have any questions and you don't have access to a microphone, you're very welcome to pop them in the chat. We've got another minute or so, and I wondered if there are no.
I have a question to our colleagues in Zambia. How frequently do you see cerebral malaria in your patients, and how difficult is it to kind of clinically judge whether what this patient is presenting with in an acute setting is due to a malarial infection or due to actually a cerebral stroke, or it's I imagine it's very difficult, and you're always having to try and exclude all the other infectious causes of cerebrovascular presentation, either with a stroke or with seizures or something like that.
That's a great question. And I would also like maybe Dr. Inambao as well to also say something about it, especially in the heavy malaria in endemic regions. So for example, Lusaka, it may not be so much, although we may have patients that would present with a picture that may look like meningoencephalitis, for example. But when you go into the northern areas, it's very common to find a patient presenting with cerebral malaria. So in terms of numbers, I do not have any at the top of my head or on my fingertips. But in terms of management, we'll usually, because of course of the diagnostic challenges and supportive maybe sort of imaging that may not be available at the time of diagnosis, we again link towards more of the clinical aspects. So we'll treat for both the cerebrovascular accident or the stroke, and also the suspected infective process. And once we're able to maybe have imaging done and so on, we're able to then either de-escalate or, if need be, escalate some of the treatment modalities. Yeah, I don't know if Dr. Chunda or Dr. Inambao.
Okay. So my comment was going to be, it's actually very difficult for a sickle cell patient when they come in that state with all the very similar symptomatology to be able to distinguish. So sometimes, of course, if we can, in most cases, I would say we can test for malaria, okay? But in terms of distinguishing an encephalitis, meningitis from a stroke, okay, many a times it's not possible to do that. And because we can't even do the imaging quickly, we sometimes kind of treat the patient as though they have, especially that the meningitis, encephalitis, and they have stroke, and then just monitor how they how they respond to treatment as you move forward. But it is quite challenging, actually. It is quite challenging. So we may give antibiotics, we may give the blood transfusion as well, addressing the stroke, and antibiotics addressing the infective problem the patient might potentially have.
Yes, I guess sometimes we do have to do the same. If a patient is mildly febrile or something, and whilst you're kind of getting the imaging through or whatever, you still have to cover with antibiotics. I think that's quite a pragmatic approach, I guess.
Mm-hmm. And I also wanted to add, when we first began to use the TCD, we're actually doing that at 2 health facilities, ours, and then there's also a health facility in the eastern part of the country where malaria is also quite prevalent there, just like the northern part. So there they were actually doing TCDs, not just on patients with sickle cell disease. They were doing TCD on patients with meningitis, encephalitis, as well as cerebral malaria. Okay, the findings of that that particular aspect, the meningitis and the encephalitis and the cerebral malaria, have not been shared yet. Okay, so we're yet to really discuss what the TCD revealed in that particular group of patients, and then compare that to what was being seen in our sickle cell patients. The sickle cell patients who were screening for stroke. And then surprisingly also, this is data we now want to evaluate at this stage. We found quite a number of children with very low velocities. And it was just very difficult to kind of interpret that. I don't know what your thoughts are, what that would actually mean, having a very low TCD velocity.
Sama, do you want to get that, or shall I answer?
I think, as I mentioned in the talk, we often are slightly worried about the very low velocities because we think about vascular occlusion, especially moya. So if we find persistently low velocities, especially in the major vessels, then we always think, is there an proximal occlusion that's resulting in a very low velocity downstream? So for those patients, we would often have a lower threshold to do an MRI, MRA to assess the vascular anatomy because of the low velocities. Having said that, there's also, it might be just operator dependent, but I think if we are confident of the skill set of the operator and we know these are likely going to be true velocities, I would be worried about occlusion and think about cross-sectional imaging with angiography as well.
Jacqueline, how young are these children who are having these low velocities? Are they older children or much younger children?
They were actually the much younger children.
Yeah. I mean, sometimes I guess if they were much younger, then I guess it's more likely to be like, they haven't had, this is kind of more like normal, and they haven't had a chance to develop the cerebrovascular disease, and therefore the velocities are kind of more what you would expect a normal, a non-sickle patient or a child on hydroxyurea from a very young age to have. So normally the children who are very well treated with hydroxyurea, normally, especially the younger ones, tend to have their velocities in the sort of, 50, 60 centimeters per second, that kind of range, which is very similar to normals. I mean, so it's possible that what you're seeing is, unless it's there is a sort of disparity between one side versus the other, and you've got really high, 100 over 100 or 150 on one side and really low on one side, that can be a little bit worrying. But if it's globally low and the child is very well and very young, then I would worry less about those values, if you see what I mean.
Okay, perfect. And then I think considering them in the context of the patient, so a severe phenotype patient with those velocities is not the same as a milder phenotype, well-managed patient with the same velocities. So just having a more holistic look at the patients and assessing whether it's relevant or not. Perfect. Okay, so we're running a little bit over time. Any last questions before we close? Okay, if there are no further questions or comments, then our next session is scheduled for the 17th of February, same time. That's going to be an MDT session. So please feel free to send in your performance with the patient's history and MDT questions as best as possible ahead of time. And we meet on the 17th of February. Thank you very much. Thank you everybody for joining.